Hello, everybody. I'm Dr. Tarman, and we are doing all sorts of ingenious ideas to try to figure out how to go virtual. And so this is like I'm using a program called Be Live, and then Janet is using another anyway, we made it in here, and welcome everybody to this talk about obesity in the COVID era. My name is Dr. Tarman. If you don't know me already, I am the addictions physician at Renaissance, and we have a food addiction program as part of the services that we offer. And it's the reason why I'm interested in speaking with the post-bariatric community, because a lot of people, once they, well, I guess the other fellow just before me spoke about weight regain. Weight regain is a possibility, and I'm convinced that, well, it's not a possibility, it's a frequent occurrence. And I'm convinced that food addiction is the missing piece of the puzzle that often clinicians don't tell you about. And Connie and I will speak much more about that tomorrow, or actually on Saturday. But today, I wanted to address an issue that if you're really tired about hearing about COVID, then go and get a coffee. But I thought it would be very interesting to talk about the risk of obesity in the COVID era and what we know about it and why we think it's a concern and all that kind of stuff. So I see that there's some comments. That's great. Thank you. That means some people are listening and watching. Hello. Okay, so I'm going to do my screen like this, and hopefully you can see what I'm doing. Just going to make sure I'm available for Connie, yes, or Janet. Okay, good. So I want to talk about, let's see, can I do this? Yeah, there. Oh my gosh, this is going to work. Obesity in the COVID era. Now, some of the stuff you know already, but it doesn't hurt to do a little bit of review. And please write down questions so that I can address them afterwards. But the thing that I want to talk about is COVID, which is otherwise known as SARS COVID-2, which stands for severe acute respiratory syndrome. And we've heard of SARS before. It was around over 10 years ago. It was something that scared everybody, but it was mainly contained in the hospital sector. And although it frightened a lot of people, it didn't spread into the community, and that's the big difference. So this is like the brother or sister of that SARS. It's a different virus, but they're both cold viruses, which are known as coronaviruses. And they're like sisters to each other, but not the same thing. Now, the thing about cold viruses, and this is pertinent to the topic at hand, is that they are tremendously infectious. And this virus, the one today, COVID-19, is extremely infectious. But, you know, lots of colds are infectious. And you'll probably remember in November, December, January, February, when we were just started to hear about this, a lot of people were saying, it's not such a big deal. Please don't worry about this. It's just a cold, but albeit very infectious. And there's truth to that statement. And then we also heard the commentary about, well, actually, it is a big deal because some people are getting really sick and even to the point of dying. And there was, you know, this sort of gradual toll of death that was accumulating, frightening people. So we almost saw like two sides, the people the naysayers and the people who are really taking this overboard and getting really frightened. Okay, I see Connie. No, okay, just want to make sure. Okay, so both of those realities are true, and I wanted to say a little bit in terms of context, because the part for our population and who, you know, the issue of today is that it's more true that to be worried about it than not. But you know, there's a lot of people who it's not like anybody's right or wrong; it's both sides. So we have these two viruses, and SARS-1 and SARS-2, as it were. And the SARS-1, which was the one a few years ago contained in the hospital sector, we were really worried about it because, yes, it was infectious, but the mortality rate was really high. And if you look down, I don't know if you can see, yeah, you can see the red, the rose-colored. The SARS mortality rate was like 10%. So 1 in 10 people could die from it. Pretty high. And COVID, this one, the sister virus many years later, the mortality rate was significantly lower, like 3.5%. That would mean that out of 100 people, 3 people would get very, very sick and possibly die. It was much lower, and consequently, people were saying it's not that big of a deal. There's other infections like the influenza that are much more of a concern. But the thing about this virus, unlike that one, is it's much more infectious. So, from a clinician point of view, we worry about how infectious it is and then how virulent or nasty it is, how much it can actually make a person sick. And in the first SARS-1, it was very nasty, but didn't get that many people sick or infectious. But whereas this one, very, very infectious, which is why we see masks and people, 6 feet away and all that sort of thing. Very, very infectious, but not necessarily a high mortality rate. But when there's so many people infected, the numbers of mortality will, just because of the virtue of the numbers of infected, will be much higher, and that's what we're seeing. So that's that's the general state. And just as to give further context, the Spanish flu, which was the famous flu, after the First World War, the mortality rate there was highly, highly infectious, probably like COVID or more, and also very fatal. So in a way, it had the worst of both possible worlds. And the other thing about that one was that you could get sick in the morning and be dead by night. It was like very fast acting, whereas COVID here, in worst case scenario, it takes 5 days to 2 weeks before you either go bad or go good. You sort of finish with it. So anyway, it's kind of in the middle, COVID too. And if it were just the 3.5%, here's where this is relevant to us today, then we would be not as freaked out as we are. But we are because that 3.5% raises up higher when we look at risk factors. And this is where we're looking at nursing homes and shuddering and just being really nervous. I'm just going to, actually, before I talk about the risk factors, because that is what we're going to talk about, I also want to explain the actual disease process, and because it's relevant also to our conversation coming up. If you're one of the lucky people, one of the 3.5, 3.5, the rest of the population, then the people who just get infected but don't have any symptoms, then we call that the asymptomatic state. You don't have symptoms, but you can still have the virus and still spread it. And the belief is that this is about a 2-week long process. It could be longer, and in fact, that's one of the things we worry about. We're not sure, but the numbers seem to suggest up to 2 weeks, with the weak point, the 5 days to 7 days, being the point at which you either, if you're going to be really sick, by then you'll start to show it, versus, but if you haven't gotten sick by day 7 or so, you'll likely be okay, but you still want to finish the 14 days. So what happens is it's acute respiratory syndrome, SARS, severe acute respiratory syndrome. What actually happens is you just get a cold, and at least that's how it starts. Now, if you look at this diagram here, with the person, the circle there, that's the nasal, oral, nasal pharyngeal area. That's where most colds that we all have go, and that's usually the end of it. And if you're not part of that risk group or the 3.5, that's where it stays, and you're good. But what can happen is any cold can go into the bronchi, and then we get a condition that's called bronchitis. It's an inflammation of the bronchi. And oftentimes people who are smokers and otherwise sick, which I'll get to in a minute, the risk factors, will get a bronchitis, and often a chronic bronchitis, which is otherwise known as chronic obstructive lung disease. So it's an infection or an inflammation that's sort of hovering in this area. The bad news, and this is the piece about SARS-2, COVID-19, is that it can actually go into the lungs. Not for everybody, but just that 3.5% or other people with risk factors. And it can actually go into the lungs, into the sacs, the air sacs, what we call the alveoli, and it actually strips the fluid from the alveoli so that you can't do an oxygen exchange. And what that actually means is you get a pneumonia. And if you actually have this because of smoking, not because of SARS, we call that emphysema. So chronic obstructive lung disease is when you have an inflammation of the bronchi and the lungs, the alveoli, because of, not because of a cold, but because of smoking or whatever else. But you can get it because of a cold. And with SARS-2, COVID-2, the thing we worry about is you get the infection, but what if it goes into the bronchi? And then, oh my God, what if it goes into the lungs? Because if it goes into the lungs and you're already compromised, this is what I'm going to talk about next, you're jeopardizing your ability to survive that. The other thing that happens, well, actually, yes, okay, so the virus itself can go into the lower bronchi or the alveoli, the lungs, as I said, and that itself you got a virus that's causing damage to the lungs, that can really make you sick. But the thing that happens that really turns the switch at around day 5, day 6, day 7, it seems, now I'm talking here about speculations that have been posed. The research is not specific because we just don't have enough research, but this is in the medical community. These are the things that doctors are talking about in the various groups when they're trying to sort out information. It seems that there's the virus, but then second, or even worse than that, there's the inflammatory response that happens to the virus. So if you have a cold, you'll notice you get bronchitis. Then the doctor gives you Ventolin or some kind of puffer that opens up the airway so that you can breathe. And they'll also give you a steroid because they're trying to deal with the body's response to that virus, which is called inflammation or an inflammatory response that can sometimes be sort of overkill. It's basically, well, that's essentially what happens with COVID. It's an overwhelming inflammatory response. So you take a steroid puffer like Flovent, or I'm not sure what the American version of that would be, but that tones down that inflammatory response. So that's why you take those two puffers. We actually find that in the case of, or even prednisone, by the way, if you've ever had to go to the hospital, you might be given pills to tone down that inflammatory response, because the inflammatory response can actually be so overwhelming, which is what happens with COVID, that is the thing that gets people into the ICU. And here's a couple of x-rays, the top one being somebody who's come into the ICU with COVID, and then days later, look at how much more foggy and white and less black is air and lung, that lung is, and that's just 2 or 3 days later. So this guy is probably going to be put on a ventilator anytime now. And that's not the virus, that is the inflammatory response. So COVID, the danger about this is if you just get it and it's contained in the upper pharyngeal area, that basically the nose and the throat, like your standard cold, no problem. But if you are otherwise compromised and the virus can get its way down into the bronchi and into the lung tissue, okay, that might be okay. But if you have an overwhelming inflammatory response, that's the thing that could land you in the ICU. And this is the piece that we don't really understand, what's going on, but this is the piece that we, that's the mechanics of what we worry about. And then when, you might be thinking, as I did, okay, so you go into the ICU, it's not great, but at least it'll save your life. But the ICU does not have a tremendous amount of success, not the ICU, the ventilator, which is why you're going to the ICU, not a tremendous amount of success. So you don't want to get to that state. But if you do, if I had to go, I would go. But if I had a family member who was in the ICU, I would be really worried, because the amount of people who come out of the ICU and the ventilator, it's only about a third who walk out fine. And others, they may survive the actual infection. Remember, it's that whiteout inflammatory response that seems to do most of the damage, that they may walk out, but they may have more compromised lungs. Like they may really have a bad case of COPD when they leave, or something like that. Even worse. I mean, we hear about people who come out and they had all sorts of horrible things that have happened. So anyway, point is that if you're not one of, if it's gone down into the lungs, it's a serious condition, and that's why it is true that this is both a benign illness but also not. It's not if you're going to be one of the people who have the risk factors that will make it go worse. So let me just go back now to, that was an explanation of the actual condition, which can lead to death, and it's mainly not mainly, it's probably equal or maybe a little bit more than just the virus itself. And who are the people for whom that is a higher possibility? That's the subject of the talk here today. We have been saying for the longest time, and it's absolutely true, that age is a factor. So somebody over 60, now I'm actually going to be 63 tomorrow, so it's my birthday, sort of. And I wrote in one of the doctors' groups, hey, I'm 60, I'm healthy, I don't have diabetes, I don't have all these things. Is this a problem just by virtue of my age? And I had a number of doctors saying, yes, it's a problem, just age related. So it's not just age equals other conditions, but age itself. When we look at the people who have died, it's been mainly people who are in their, well, here's an actual graph here. I said 60. So, I mean, we're going from 1.3%, and here, these numbers here, 0.2%, like not even 1%. These are the people that are going to the parks and are like saying, well, I can get this thing, it's not going to affect me. And true enough, they are not the people that are going to be affected, all those young people in parks and on beaches, tanning. It's the fact that they will carry the virus, be asymptomatic, or have a mild case of a cold and give it to us, their parents and their grandparents. So by the time you're my age, it's a 3.6%, but not much longer, in 7 years for me, it'll be an 8%. In other words, almost 10%, which is almost the Spanish flu level or the SARS 1. And if you're over 80, oh my God, look at that, you're looking into the 14% and higher. No surprise that people in nursing homes are really affected, because age itself and then multiple conditions on top of that are a problem. So we've been saying age is a big issue, but now more and more we're saying that obesity too is an issue. And when we talk about obesity, of course, we're always talking about the BMI. And of course, I'm sure all of you have seen a slide like this before. We're not talking about the overweight category between 25 and 30. We're talking about 30 plus and often 40 plus, a BMI of over 40. So that would be, I don't know if you can see, I don't think you can see my cursor there. Can you see it there? This here, or 30 or 40, depending on the study. Not overweight. We're talking about obese, or what is often seen as severely obese or morbidly obese. Is it the risk factors itself, or is it the weight itself is the thing that we're not sure about? This is basically, I want to say, just off the press kind of research. And which, by the way, the press always has the research first, and then the New England Journal of Medicine, which is a very esteemed publication, is not far behind. They're pretty good. But the stuff where the really good data is, that hasn't even been published in a way that is accessible to most of us clinicians. The press get this stuff long before we do. Anyway, so we're left kind of speculating. What's going on? Is it obesity? Is it the coexisting conditions? So this is a slide, actually comes from the New England Journal of Medicine. So I trust this diagram very, well. It kind of gives some of the explanations with the idea of it being the coexisting conditions. Because if a person has obesity, they have these conditions, and maybe that's what's causing the this ability for a simple cold to manifest into this pneumonia, which is what we're worried about. And so the very first thing I'll say is the thing that's, I guess, the most obvious is that if a person and I'm not talking about post-bariatric where people have lost weight, because then you have taken care of this angle of things. But anyway, I'll just continue on. If you have a fair amount of weight in the abdominal cavity, and you're not able to take a deep breath, I mean, basically just lung function is compromised. You can't breathe as deeply, you can't breathe as well. Essentially, you're becoming compromised. You may have, because of the compromise, what we call pulmonary hypertension. It's like hypertension, but in the lungs, so that you can't, the lungs are working a lot harder. You can't breathe as well. There's just it's like everything is more constricted, and essentially impairing your ability to breathe. Impaired gas exchange is probably got to do with some of that COPD, emphysema-like process that's happening. You're just not getting the oxygen and relieving of the carbon dioxide that you need to breathe well. Low lung volume because of you can't take a deep breath because of the abdominal adipose tissue that's kind of getting in the way. So it's almost like structural issues happen with obesity, and those structural issues compromise lung and therefore make it harder to fight off lung infection. Okay, so there's that. I haven't actually touched the immune piece yet. I'm going to get to that. When you have a lung that's working harder, the heart has to work harder because it's a heart-lung process. The heart is pumping blood through the lungs to get the oxygen, to get it to move to wherever it has to go. I mean, you take in the oxygen through the lungs, and then the blood takes that oxygen, which is carried then by the hemoglobin, to the body. So it's a double effort, and the heart is having to work hard. If you've got high blood pressure, if you've got cardiovascular disease, high lipids, then your heart is working harder and can't do the job that the lung is not doing a good job of. So that's another reason. You basically can't rid the virus, and you can't get the oxygen that you need. The virus is, destroying lung tissue, and if you already have impaired lung tissue, you're in more trouble. There's been some connection with diabetes and sugar, which I'm going to talk about shortly. So I'm going to hold on that one for a second, but there's a strong link there. Kidney disease, often related to obesity and diabetes, and it appears that it has its own individual piece as well. Something to do, well, anyway, I'll just leave it at that, because I don't know enough about that to comment too much. What we call metabolic risk or metabolic syndrome, high blood pressure, pre-diabetes, insulin resistance, and high, these are all related to, not sure how, to this as a risk factor for COVID, for this thing becoming from just a cold into a pneumonia. So that's where we say the pre-existing conditions of obesity lead to COVID. And now, as I said a minute ago, maybe just obesity in and of itself, just like age in and of itself. Also, I forgot to say, if you're a man, men are higher. I was surprised at that. Men are higher, more likely. So if you're a man and you're over 80, oh my gosh, well, anyway, I'll let you finish that story yourself. Okay. So I've talked about obesity, the kind of respiratory, mechanical things that make you unable, like you can't ventilate, hypoventilation, causing stress on the system. The coexisting conditions like diabetes, high blood pressure, kidney disease, all seem to make a person more predisposed to COVID pneumonia. And then there's been talk. And here's what we're talking about, not yet research, but talk about that obesity itself, not the coexisting conditions alone, although they often have the same, it's all the same function, but the obesity itself, the adipose tissue itself, that it seems to contribute to that inflammatory response that makes COVID very serious. So you've got the cold that goes into the pneumonia, just the viral pneumonia. But then when we get that whiteout inflammatory response, that's the piece that has the person end up in the ICU. And it appears that the adipose tissue contributes to inflammatory molecules that contribute to that inflammatory response. All right, I will, let me see if I want to say anything about that. Yeah, okay, so it appears to, so an increased inflammatory response. So if having a higher BMI just in and of itself has an increased inflammatory markers, which can then lead to this potential cause of COVID pneumonia, we already know some of this information. Doctors, especially bariatric clinicians, in other work, like we've seen that these inflammatory markers appear to have a fact in the development of fatty liver disease, or what we call visceral obesity, which is the abdominal obesity. It seems to contribute in insulin resistance and diabetes, in heart disease. It's already something that's been targeted as there's something about these inflammatory markers that we have to change. If I can just point out that normally when a person has a high inflammatory response, the no-brainer for an ICU clinician and a doctor would be, well, let's reduce the inflammation. Let's put them on prednisone, or let's give them some kind of puffers that will reduce the effect of the inflammation, like we do with bronchitis. A person takes their Flonase. Let's just double up on the Flonase. But we found for some reason that that actually makes things worse, so that we can't actually we've got this inflammatory response. We can't use our standard anti-inflammatory treatment. So we're just left basically having the person go into the ICU and sort of holding our crossing our fingers, hoping we can keep the person alive and that they can fight off that infection so that they can come out on the other side well. And that it's just a thing. So this concept of the inflammatory markers is becoming ever more important, because it seems to contribute to the coexisting conditions of obesity, and it seems to be in and of itself a problem just because of obesity itself, not even the coexisting conditions. So that's, as far as research and science goes, that's kind of where we are with COVID. I want to add a piece because I'm interested in food addiction and sugar addiction. We know that I've said here, increased inflammatory response contributes to the development of insulin resistance and diabetes, which is often the very serious condition that happens with obesity. And thankfully, with surgery, it's one of the first things that gets resolved. It's often the reason why somebody who might otherwise not do surgery will do it, so they can get off their insulin and treat their diabetes or have it normalized. So that this is a really important piece. We know that, let me see here now, yeah, that blood sugar, now we don't know why, but there's something about, and this is research that I just found, and I was really intrigued because I'm interested in this whole area of sugar and the impact addictively wise, which is what Connie and I will be talking about tomorrow. But we know that high blood sugar can trigger this possibly this whiteout inflammatory COVID pneumonia. So I mean, here, I'm just going to read this. The glucose metabolism, sugar, plays a key role in that cytokine storm, which is that whiteout that we see in not just COVID, also in the flu, the influenza, or COVID, and could have the potential implications for the COVID infection, pneumonia. So high blood sugar in the context of an infection can contribute to that whiteout effect, that very serious complication of COVID. So what does that mean to us? If there's anything that we can do aside from controlling diabetes, which might be through bariatric surgery, it might be through medications or whatever, certainly try to have your sugars under good control. What we do know is, let me just see if I wanted to, let me just jump to this. New research shows that a viral infection can activate this glucose metabolism. So in the context of a virus, sugar will cause more of an inflammatory response, which is the breeding ground for COVID. So bottom line that I want to say is, as much as you can, if you have diabetes, control the diabetes. But the other thing is, and this is going to be our message tomorrow with addiction, try to cut down on any sugar that you're eating, because it's just feeding this potential inflammatory response. A high sugar diet for anybody, regardless of weight, is associated with higher inflammatory markers, which then lead to the fatty acids. You can have a fatty liver and be thin. You can have a fatty liver and be young. You can have, female, male, whatever. A high sugar diet will lead to insulin resistance and diabetes, and this obesity, the visceral obesity, abdominal obesity. And it's also associated with other conditions, not just COVID pneumonia, but dementia, depressions, Parkinson's, etc. We could go on about that, and I'm happy to do so either today or tomorrow. But bottom line that I want to leave you with personally here today is, if you have any kind of sugar in your diet and you have any of these risk factors, you're male, you're getting on the older side, on the lesser side of 60, I don't know if it's the better or worse side, and your weight is a BMI of 30 or plus, do yourself a favor and cut out the sugar, because it will, it's not like there's something we can do to protect you by giving you something. This is an abstraction. This is a subtraction. Subtract a negative risk factor that has been associated with many diseases, including COVID, pneumonia. So, summary. That was a lot of talking. I hope I have some questions to elaborate or whatever. Summary that I want to make is, COVID is both, for many people, for many young people, not that serious, except that they will carry the vector, the virus, to people for whom they do have risk factors, which are higher age, male, and obesity, higher BMI of 30 plus, especially 40 plus. What we're worried about is that infection will move from the nose area, throat area, into the lungs because of those risk factors. What can we do about that? We can make sure that, as much as we can, control diabetes. And then as a simple, it's not that simple, but as a simple precaution, maybe it's simple but not easy. Quit any sugar or basically foods like flour, foods that are almost sugar, like bread and pasta and stuff like that, as a way of removing yourself from being in that higher risk into the better risk. That is my summary, and I am now open to questions.